We'll do a brief overview of our agenda here. We'll do, obviously, the welcome, which we've just done, and some team introductions, along with some team sharing. That'll lead us into our quality improvement framework, and we'll start to talk a little bit more about PDSAs. Dr. Heather Fry will take over and discuss the clinical content today, which will focus on the ask and advise, and then we'll have time at the end for any questions. All right. So today, as I mentioned, Dr. Fry and myself will be leading the majority of this conversation, but we also have our project management team behind the scenes helping to support these efforts as well. We wanted to make sure that we recognize them. Today's objectives to utilize PDSA cycles to help guide performance improvement efforts. So we'll get started on that piece, and then employ evidence-based guidelines using the 5 A's, the ask and advise, for smoking cessation with pregnant women. All right, and this screen is one of my favorites just because it does show that our teams are participating throughout the state of Ohio, and you can see we have representation from across the state with us here today. So that being said, and I have not, it looks like we have a bit of 15 participants with us. And I just want to make sure we have a good sense of who's with us. So do we have anyone from Access Point on the call? All right, what about Crossroads? I think I saw Dr. Ferguson. All right, Dr. Ferguson, you might be on mute if you're trying to talk. And again, if you have difficulty communicating, utilizing the chat box is also a great way to do so. All right, and then, very good. So then anyone from Brown County Women's Health? I'm striking out. One of these times I'm gonna get a voice to come back on me here. All right, what about Grant Medical Center, Ohio Health? All right. Well, we have lots of people on the phone, so I'm wondering if there might be some audio issues that we might be coming across here. Do we have anyone from Lane Women's Health Center? Okay. In the chat box, oh, there we go. Dr. Ferguson called in from her cell phone, so she cannot utilize that function. And then we have Bethany Luck from Lane Women's Health Center. Welcome, Bethany. How about Cleveland Clinic?
She said she was going to have to call in.
Jennifer, are you on the line?
She is like having to go.
All right, wonderful. And finally, 3rd Street. I know that there's a large contingency from 3rd Street. Can you all hear us okay?
A little quiet. I don't think I can make it any louder.
No, it's as loud as they get.
What's that? Is our volume? I'm hearing some feedback in the noise, and I don't know, or on the line, and I don't know if it's in regards to this call, but they said it was a little quiet. Everyone hear us okay?
There's a message in the chat box that says,
okay, perfect. All right, and Jennifer, I see that you're here, Jennifer from Cleveland Clinic. So, all right. And as I said before, as we move forward with this call, we will be taking a collaborative approach and sharing some of our learnings along the way. So we really encourage everyone to participate in these discussions. All right. And the first time out, it's a little bit funky, and that's quite all right. So, all right, moving along here.
Not a big fan of them.
All right, we're going to go to our team sharing. And during our virtual learning session in the end of April, we talked about the 5 A's intervention worksheet and starting to implement that within your practice. So a couple questions that I'd like to ask for team sharing is, how is that implementation of the 5 A's worksheet going within your practice? And then based off of the 5 A's, what's your team's greatest area for improvement? And then are there any issues with the PRAC 2.0? So I'm going to open this up for discussion, and I just want to start hearing from you all about how the 5A's worksheet is coming along for everyone, and any challenges or successes that our teams would like to share thus far that they have had. You can also utilize the chat box, where I can start calling on some folks as well.
I can start. This is Dr. Ferguson from Crossroad. Can you hear me now okay?
Yeah, perfect.
Okay. So we have kind of taken a team-based approach to using the 5A's worksheet. We have a couple of prenatal doctors as well as nurses doing our initial prenatal visit, and then we have behavioral health consultants as part of our team as well. And so we've kind of said that the behavioral health consultants or the doctors are going to be the ones completing the actual form, but then our nurses doing the initial prenatal visit are kind of the first line and doing the first question of asking and doing the screening at the initial OB visit. And so we don't have a huge population, but I think since we started, we've maybe done 5 or so worksheets, which I think is actually pretty good and exciting for us. I don't think we've missed any patients that have screened positive for smoking. I think we've been able to complete it on all of them. And I have seen just all of our team members jumping right in and getting on board with using the worksheet. So I think it's been going really well. I think that one challenge is that just the referral to resources part. I think we don't have a tobacco treatment specialist on site, so we don't have that option. So we have been referring to the Quit line. We have actually been able to get some print resources from, I guess it was from the Ohio Department of Health. They sent us some print resources, and so we're just working on distributing those just so that we can have some more on hand for our patients.
Okay. That's great, and that's I'm actually very happy to hear that you've been able to implement it with five or so of the patients. What has the feedback been as far as, has the tool been helpful to help for the clinicians who are utilizing it to give them guidance with their smoking cessation efforts in the conversation that they're having with patients?
I think so. I think it particularly has I think it has shown us that we don't have a great handle on the resources that we can send patients out of the office. I think we're pretty good at some of the motivational interviewing, setting goals, and kind of tailoring our counseling to the patient, just because we do that with a lot of other medical conditions as well. And so I think we've had practice with that. But as far as smoking cessation resources that are particular to, even to pregnancy, I think we've been able to realize that's an area that we could improve, and it's prompted us to take that one step further and go ahead and do that and make the referral, kind of formally tell the patient, hey, these are the resources that are available.
Great, and we'll talk more about the referral piece as this project progresses, but that is one of the reasons why we switched over to the PrAP 2.0 to make sure that this information gets into the PrAP 2.0, because it does assist with the referrals for the needed resources, including the managed care plans, which actually have a fairly decent smoking cessation programs. It's just a lot of the organizations may not be aware of them or be aware of how to connect the patient to those resources. And so the PrAP does help with that. So we're excited to see how that helps enhance everyone's smoking cessation efforts. And I see here in the chat box, Jennifer from Cleveland Clinic, you made the comment that you're working on including the 5A's worksheet into your Epic system. And so one thing I like to point out here is, it's kind of cool, is that Crossroads is a little bit smaller organization, and they're figuring out some of the processes that work well for them. And Cleveland Clinic obviously is a much larger organization, and they're looking at a different process. And both are great in the sense that the purpose of quality improvement is not to be prescriptive and say you must do X, Y, and Z. the purpose of this project is to help our teams identify best, or to share best practices, and then have our teams identify how they can incorporate those best practices into their everyday workflow. So thank you, Jennifer, and thank you, Dr. Ferguson, for sharing those. Do any other teams, would they like to share some of the successes or challenges that they're initially having with the implementation of the 5A's worksheet?
I would like to share. Can you hear me?
Sure.
Hi, I'm Kendall Lindsay. I'm the tobacco treatment specialist with Tri-Health down in Cincinnati, Ohio. So being the only tobacco treatment specialist on staff, I've been making it a really good point to reach out to all of our practitioners and providers. So before I got here, they went ahead and started actually using the 5A's intervention worksheet, and it's been going pretty well. I think that it's been making our nurse practitioners especially confident in having that conversation with the patient, along with all the other things that they have to address. I feel like with me being on staff now, it makes the transition a little bit more of a warm handoff. So mom is more comfortable, speaking to someone who is solely here for the smoking piece of her healthcare. So far so good. I pick the sheets up currently about every other week because my fear is that with it being a piece of paper, it's a tangible item and we can lose it. And we don't want to lose that. So I pick them up and I keep them in a secure area in my office for the time being. I know that last time I spoke with Dr. Marcotte, we were in the process of getting a business agreement settled so we could scan them into the system. So that would be great and a nice advancement. But similar to Cleveland Clinic, we've also decided to go ahead and put our 5A flow sheet inside of Epic. It's just easily accessible for all of the team members on the care team and things like that. What is your team's greatest area of improvement? Greatest area for improvement is just remaining in constant communication with each other, because sometimes we have mom, prepared to go ahead and quit, and sometimes the contract can be a little bit scary in terms of signing a quit contract before talking to me. So just making sure that we pass, that it's passed on to me and I can talk with mom, working on her with her motivational interviewing, and then we can go forward from there.
Wonderful. Kendall, thank you so much for sharing that information and what Tri-Health is currently working through in their processes. And also thank you to Dr. Ferguson and Jennifer for sharing as well. So, and again, another highlight that as I was sitting here thinking about this, Kendall, your perspective from being a tobacco treatment specialist is very unique, and I know will add a lot of value to this collaboration as well. So thank you for sharing what Tri-Health is currently working on and their approach, and also look through their lens. So very much appreciated.
Thank you.
All right, so we are going to go ahead and move on in the interest of time. We do have some additional content that we need to get through. But again, if just a note to the PRAF 2.0, please reach out if you are having any issues accessing the PRAF 2.0, getting your organization set up with the PRAF 2.0. I know that the majority of our teams are already set up and are highly functioning with that the pregnancy risk assessment form. But if you are not, we have resources here at OPQC that can help you and your team get that process and system established. And that is part of a big part of this project, especially with the data collection and referral resources, is that we do have that PRAF 2.0 set up with our teams. So great, thank you everyone. All right, so the next topic we're going to start on is looking at PDSAs. And this will be a chat box question of those of you on the phone. How many of you have worked on a plan, do, study, act cycle, or a PDSA cycle? And please just go ahead and type that into the chat box real quick. And it doesn't necessarily have to be formal, but have you been involved in working on it?
Yeah, we started one, but I don't know where it's at.
Dr. Ferguson.
Crossroads has, wonderful. I know you participated in the progesterone, some of the progesterone work, so I'm sure they had, in fact, I know they had you do some of the PDSA cycles there. Yep, perfect. Okay. What about, Puppy Grove? That's wonderful. Thank you, Polly, for sharing. Any of our other teams out there working on PDSAs or worked on PDSAs? I know that Cleveland Clinic has, just because they participated in other OPQC projects. 3rd Street, have you all had experiences with PDSAs? All right, wonderful. Lark grant, perfect. All right. So I just want to give you, and this will just be more of a high-level overview then of the PDSAs, as it looks as though some of you have had some experience in this. So we use the Model for Improvement as our framework to guide our quality improvement efforts. It's composed of 3 basic questions that help us focus on our aim, objectives, measures, and also includes the PDSA cycle to test changes. Answering the 3rd question here, excuse me. Answering the 3rd question here requires developing changes to test. All improvement requires changes, but not every change obviously is an improvement. And I think that's true in all of our lives, in our everyday life for sure. So now we need to figure out where do the changes, what are the changes that are needed to result in a positive improvement for your practice. This next slide here is then, when we look at our PDSA cycles, we're looking to test change on a very small scale when we first start out. So that being said, what is a test? Putting a change into effect on a temporary basis and learning about its impact. So why do we test? We test to reduce the risk of implementing an intervention that may not be the best intervention to implement, as we mentioned earlier, that not all changes result in improvement. So testing is a good way to kind of test the waters before we go in full board. To either increase or decrease our belief that a change will result in improvement. To learn how to adapt the change to other conditions in your environment, and then to minimize the resistance with implementation. If you are able to, especially in the clinic environment and the acute care hospital setting environment, if you're able to evidence with small tests of change, a positive impact, spreading those changes throughout the organization are going to be much, much easier to do so. So what is not a test? Data collection. Data collection is good. It is wonderful. We use it to help guide our improvement efforts. However, it is not a test. Implementing a solution. Yes, that can help, but we need to make sure it is the right solution that we're implementing. So that is not a test. Rolling out educational programs. So many times we say that our solution to problems is we're going to educate, and that might work for 2 or 3 months. However, we know that education is proven that it does not necessarily sustain the change that we're looking for. So many times we'll have, in my previous world, in the acute care world, we'd have the Very Strength Commission and CMS come in and, what are you going to do about it? Oh, we're going to educate. And we look good for 3 or 4 months. And then after we got done with our education period and everyone was compliant, you see that dip back down. So, and then also getting a form, policy, or procedure approved by various committees is not a test. All right, so PDSA cycles. We look at PDSAs where you start with one and then you move on to the next. And so that's when we talk about cycles. What we're talking about there is we start with one small test of change. Based upon the learnings, what are we going to do next? So it's not all in, all at one time. So again, think small, developing details, plan to execute the test of change, the who, what, when, where, and why. Be methodical and make predictions, and allow for rapid adoption and implementation of changes in the busy healthcare setting. Key points for Plan, Do, Study, Acts. We want to do initial PDSAs on the smallest scale possible. And as I mentioned before, or as I mentioned, you want to start small. So start with one patient, one day, and see how that test goes. Your next test. Start with one clinician one day. your next test. Move that off of 1 day to 2 or 3 days. So continue to grow your testing just to make sure that you're not doing anything additional work that's not needed or that's not going to show positive change, and making sure that you're learning from the cycle. Test under as many conditions as possible. And then always identify your prediction or hypothesis in testing change. And again, allow learnings from your failures to continue to refine your theories. And then study measures that are specific to the PDSAs. And that's to the point of the PRAC 2.0 and the various measures that we're using within this project. That is the purpose, is so that we can study the change. As I mentioned before, starting small, the power of one. 1 day, 1 physician, 1 patient. After the call today, we will be sending out this sample worksheet. And this sample worksheet really helps teams come together to help determine what they want to test, what success looks like, how you're going to measure it, what do you predict will happen, and then the data that you'll be collecting. This isn't anything that's super formal or super hard. Again, it's just very basic information, but it does help provide guidance to your PDSA testing. So we have just a few more minutes here before I'm going to hand it over to Dr. Fry, but I wanted to show you an example of a PDSA incorporating the 5A's intervention record into the smoking cessation counseling effort. As you can see here, this is our key driver diagram, also known as our roadmap. And what I've done here is the red circles. You can see one of the key drivers is clinical knowledge and know-how and confidence in supporting smoking. And the intervention is, or the how we're going to do it. So what we're going to do, it's the clinical team knowledge and how we're going to do it. We're going to incorporate smoking cessation approach that utilizes the 5A's intervention, or 5A strategy and motivational interviewing. So if I was to run a simple PDSA cycle on this, we're looking at making a plan. So what are we going to test? What are we going to test? Was the information needed to complete the 5A's intervention record easily obtained from the patient? So you're looking at the flow of this. And this is just an example. How will you measure success? We're going to measure it through the completion of the 5A's intervention record with 1 patient upon initial visit. We've defined what success looks like, making sure that all the questions in the 5A's intervention record are accurately filled out. And then our prediction for 1 patient is predicted that the success will be achieved through a complete and accurate 5A's intervention record. And then our plan for data collection is to review the record and then also get feedback from our staff on the ease of collection. So again, that's just one very simple PDSA to help frame it in for you. Don't overthink it. It's pretty straightforward for when you start your own test of change. And I did go through that a little bit quicker than I intended to, so I apologize. But I want to pause here for a second to see if there's any questions. And you can either ask those over the phone or you can type them in the chat box. Dr. Fry, while we're waiting for some questions, do you have any, would you like to share any of your experiences through the PDSA testing that you did with the team, with the OSU team in phase 1 of our Smoke-Free Families project?
Sure. So, I think most of our work was kind of focused on how to start getting the residents, who are the ones who are seeing the patients primarily, as well as some of the nurse practitioners, to really be filling these out on a regular basis. And so it took a little bit of time to make sure, kind of figuring out who was going to be the person to fill it out, what we were going to do as a reminder, so it ended up being that we decided that the nurses who staff the clinic would, at the first visit, initially fill it out or at least present the resident with the form to fill out. And then we had sort of a centralized location where we would collect the completed forms, and that worked really well. Another thing that we haven't been as successful in, but I think is probably a next step for us, is that we use Epic and making sure that smoking is added to the problem list on every patient, and then potentially even expanding beyond that to make sure that, under the section for smoking in the electronic medical record, maybe keeping some information such as that's in the 5A's form. So I think that will allow us to make sure that that's documented in a better way that everyone can see it. So I think that is going to be probably our next step.
Great. Thank you for sharing that. And it's very important as we go through this work, not only to share the successes, but also the challenges, because there's a good chance you're not the only one experiencing a similar challenge. And so if we can learn from each other and help remove those barriers, that is, again, one of the great advantages of these projects. So thank you for sharing that, Dr. Fry. Do we have any questions from our teams regarding PDSAs? All right, I'm going to go ahead and pass it over to Dr. Heather Fry, who's going to start the conversation about the Ask and Advise. Dr. Fry?
Thank you. So as Mary had mentioned, in these action period calls, we're trying, at least for some of them, to focus on each of the 5A's. And in this first one, we're actually going to tackle the first 2 A's, ask and advise. So this is just another view of the key drivers diagram for this project. And highlighted in the red boxes are the ask and advise. So you can see in the left column, their middle column, are ask, we want to identify pregnant women who smoke, and advise to be able to provide them with support and information about the harms of smoking. And so listed underneath the interventions are some of the things that we have thought of that we could do to really address these first 2 A's. And we'll talk about those a bit more in the next few slides. Here again is a view of our 5A's intervention form. As a reminder, under ASK, especially at that first prenatal visit, we're asking teams to really ask every single patient who comes in for prenatal care about their smoking history. Not just whether or not they currently smoke, but whether they have smoked in the past, and get a better sense of when they quit smoking, because we know that someone who quit smoking as soon as they found out they were pregnant or in the month or 2 leading up to pregnancy, compared to someone who's been abstinent for 10 years, the risk of relapse is probably different. And again, it's really important to ask about other forms of tobacco products as well. Just with the advised column, this is, when you move to this column, it's really only for those who are smokers. And we've listed there some of the topics to focus on. Next. So this is data from the initial systems inventory that we had all of the teams fill out prior to the initiation of the study. And we grouped our questions based on each of the 5A's. So these are the 3 questions that we asked regarding the Ask A. First is, at the initial visit, is a standardized screening tool used to identify pregnant women who smoke? And fortunately, most of the groups are already doing that or planning to do it. But many less groups are actually reevaluating a pregnant woman's smoking status at follow-up visits. And this is common among obstetric providers, but this is a really important thing for us to work on. I think if you're thinking about things that you could do as a next step, this is really key. And not only, you could ask every patient again at the next visit, but I really think the focus should be on smokers at subsequent visits or those who recently quit. And then lastly, we asked about the use of the PRAF 2.0 on all pregnant patients on Medicaid to communicate smoking risk and need for resources. Again, not all the teams were doing this at the beginning of the project. We hope more of you are doing this now. And certainly we are happy to work with you to try to integrate use of the PRAF into your practice. With regards to advise, we asked about the use of scripts to increase comfort with the smoking cessation discussions. Very few sites are doing this. I think that's not a bad thing. I think as we talk about how to advise women, scripted responses may not always be the best. But if this is something that you struggle with, either personally or within your team, sometimes starting with a script is a good way to sort of practice the process of providing advice. And then once you become more comfortable with that, you can, ad-lib a bit more. And then many sites have smoking cessation educational materials that they're providing to the mother and any significant others or other members of the family that are there, which is great. So again, the 5 A's: ask, advise, assess, assist, and arrange. Ask. The goal here is to identify and document tobacco use status on every patient and every visit. And with advice, we're recommending that you provide clear, strong, personalized, in a personalized manner, urging every tobacco user to quit. So as we think about the importance of this project in asking about tobacco use among all women who present for prenatal care, it's important to keep in mind the prevalence of smoking in pregnancy. Well, fortunately, overall rates of smoking in pregnancy are declining over the last decade or so. Ohio still has one of the highest smoking rates in the country. 1 in 7 women who are pregnant reports that they have smoked during their pregnancy. And that's a rate that's about twice the national average. So this is really an area of focus for our state. Smoking is a behavior that spans all demographic characteristics. But that being said, there are some risk factors for smoking, or there's some factors among women who smoke that are more common. In the graph on this page, which comes from vital statistics data, you can see that among women who smoke during pregnancy, the highest rates are in those who are in their teens or 20s. So just keep that in mind when you're working with your patients, so that may be a high-risk group. Other characteristics are white race, lower level of educational attainment, and women who are uninsured or on Medicaid are also much more likely to be smokers. It's an important first step to identify any women who need counseling or support for tobacco cessation. And so don't just ask, as I mentioned before, not just targeting those who may be smokers. You really need to ask everybody. Don't make assumptions. Try to identify anyone who's a current smoker, but also identify those who recently quit, because they may need continued support throughout the pregnancy. And again, asking about other tobacco products is really important. In certain populations, for example, in the African American community, use of cigarillos or cigars may be more common. Other groups may be using hookahs more commonly, and so it's really important to broaden what we're considering tobacco use beyond just cigarettes. And you want to make this process of asking about tobacco cessation a routine part of your office system, and document tobacco status in a place that's seen by every staff member. So I think people sort of wonder, well, does it really need to be every patient every time? One thing I'll remind you is that I think many offices, I know when I've just gone to see an eye doctor, they ask me about my travel history because they're trying to find out about Zika exposure and exposure to Ebola. Now, how many patients do we see that are really exposed to Zika or have a risk for that or Ebola? Nevertheless, we ask all women about that during their pregnancy in most of our practices. At least that's what's advised. If we can do that, or they can do it at an ophthalmologist appointment every time we show up, I think we can certainly ask all women about tobacco cessation. So we just need to put it in the context of how important this question is. And the advice that we provide patients is really important. We shouldn't underestimate the role that we have. Women are much more likely to quit in pregnancy than any other time in their lives, and our advice is a very important motivator. Smokers have reported that if they are advised to quit by a healthcare provider, they are nearly twice as likely to express a desire to quit smoking. So when we provide advice about tobacco cessation, this is a time when we can provide education about the harms of smoking, particularly in pregnancy. These include risks of things such as congenital malformations, such as gastroschisis, cleft lip, higher rates of placental abruption, previa, growth restriction, preterm delivery, stillbirth, and infant death. Now, I'll say from a practical standpoint, I don't go through and list all these things to patients. I think that's where some of your educational resources, handouts, maybe posters that you have in your office can be really helpful. But it's really important to really focus on maybe those factors or those particular harms that may be most important to your particular patient. So in providing advice, be strong and clear. No waffling. Make sure that the patient understands that yes, you understand that smoking or quitting smoking is hard to do, but in no uncertain terms, your advice is that they should quit. And personalize your advice. So like I said on the previous slide, there are lots of risks, but focus on the risk that's most important to your patient. I see a lot of women with a prior preterm birth history. So one thing I may say to them is, while we are going to do X, Y, and Z, give you progesterone, follow your cervical length, do all these things to help reduce your risk of recurrent preterm birth, one of the most important things that you can do personally to reduce your risk is to quit smoking. What to emphasize, it's never too late to quit. Just think about the long-term effects that smoking can have on the woman's health and the health of her children by exposing them to secondhand smoke. So even if it's, the patient's 36 weeks and she's ready to quit, that's great. Help her do that. And while we should applaud women for cutting back on their tobacco use, you should always keep the goal in mind that they should be quitting smoking. Reduction in tobacco use is not quite enough. It's important for the patient to maintain a smoke-free home and car during pregnancy, as well as after birth. It's really hard to quit smoking if there are people who are constantly around you in your home who are smoking. And so in part, that's to help them be more successful in their quit attempts, but it's also important to reduce the exposure to secondhand smoke, not only for the patient, but also for her family and young children. So that's the information I have today about Ask and Advise. But at this point, we'll open it up for any questions.
And just as a reminder, you can ask the questions in the chat box or take yourself off mute and go ahead and ask the question that way as well. Dr. Frey, I do want to, as we're in the room listening to you, and one of the most impactful statements you made is, in my opinion, if we're able to ask about the Zika virus and Ebola on every routine visit that we have to the doctor, it almost seems, I don't know, crazy that we're not asking about smoking every time. To the point is, it's just so, it's much more common than those other viruses that you had stated. So when you frame it that way, it's like, oh, okay, we can do that. And so you drive home a really good point. Were there any in your organization, any difficulty with the culture change associated with smoking cessation and that first step of asking and making sure that was part of your everyday practice for every patient? Did you experience any challenges with the culture shift when that was something that you all were focusing on?
I think it's more a matter of documentation than maybe it really happening. I think that most people are pretty good about asking at the first visit. Again, we use Epic, and we have our residents have smart phrases that they use. So the first visit, there's a section that they all fill out about substance abuse and exposure to alcohol and tobacco. And so I think that is done pretty routinely. I think it's a little bit less convincing that every follow-up visit that it's always readdressed and sort of how it's readdressed. I think how it's readdressed and how the patients ask. I think asking is easy. You know, I do this routinely in my practice that if someone smokes, it ends up in like the problem list that I have and that it's always there. And so every visit I have sort of a reminder to myself that I need to ask about their smoking. And I write down, oh, they were a smoker, but they quit. I still ask, hey, how are you doing with quitting smoking? Have you had any relapses? Have you had any issues with that? And so that becomes a routine part of the practice. And I just don't know that everybody does that as consistently, but part of that may be an issue of documentation. I think too is that, you know, I tend to think that the younger generation and the younger residents and medical students, that as part of their education, there is an emphasis on behavioral changes and motivational interviewing, that they're more attuned to that. And I think probably some of my partners who are older and in practice for longer, that's not, you know, especially in a high-risk obstetric practice, I don't know that they view that as being such an important aspect of the care that they provide. But certainly I think you could argue that it is just as important as some of the other things that we do. So I think I think the documentation of it is key, and I think that will help to determine whether or not everybody is really doing that.
Mm-hmm. And that's a really good point that you have about the varying degree of experience and kind of the new folks coming in versus the individuals that are you know, have the well-experienced and well-seasoned clinicians, and just their perspective and where they come from. I think that's important information to consider when you're looking at changing processes and what is needed in your clinic setting to work on implementing smoking cessation and the importance of it. Because time and time again we hear, oh, we don't have time for that, it's not worth it, it's not going to make a change. And that might not be as much of a problem if you're in a setting where you have some of the newer clinicians where that is more of a focus coming right out of school versus, you know, and the previous educational pieces in the seasoned folks, that may not have been a primary focus, as you said, especially in the high-risk OB clinics. So great insight on that. Any questions for Dr. Fry? All right, and as we move along again in the series of these AP calls, please don't be shy and speak up. Dr. Fry has a wealth of expertise, and that's why we have her as our subject matter expert on this call, and you know, is a great resource to have for everybody, and you all have access to her during these calls. So please speak up and don't be afraid to ask the questions. All right, we are coming upon time here. I do want to mention the next steps. Continue your PDSAs on identified areas of smoking cessation. We will send out the worksheet that I mentioned earlier today to help guide your PDSA cycles, to provide you some framework for that. We will be asking some teams to talk about their PDSAs on our next call and what they have learned from the areas that they have chosen to focus on. And so again, this is part of the collaborative learning and discussion. The next piece here is, if you've not done so already, please access the SharePoint site and for both public and for the teams. We will be putting the slides from today's call up on the SharePoint site for reference, and then also the worksheet. Not only will we send it out, but we'll also put it in the SharePoint site. If you've not done so already, please get me your Medicaid population and your percent Medicaid volume. That would be very much appreciated, and I know I've had several conversations with various team members about this, and so we're making some great progress on getting all those numbers complete. Last but not least, completing your monthly progress report. We will be sending out a link. It will come from data@opqc.net. So please do not put it in your spam mail. Please do not put it in your junk box. Asking you to complete a monthly progress report. And it's very simple and straightforward. The instructions will be in the the text of the email. But again, basically, once you get this email, just read through it. The instructions are simple, and a few clicks, and we'll have that complete. And then one final note. Again, many of the teams I've spoken with already about motivational interviewing and getting that on the schedule. We spoke with Dr. Gretchen yesterday about some availability for the month of June, and we just wanted to put this out there. If there are any teams that are interested and have the availability for June, Dr. Gretchen is available both the 26th and 27th of June. So if you and your team are interested and are able to accommodate for a 3-hour training, the slots still are available. The coming months after that, there will be some limit to availability. Every team will get training. So let me just first state that. We're just trying to get the ball rolling to make sure that our teams get the motivational interviewing training sooner than later. And so that being said, that's why we just wanted to block off some dates with Dr. Gretchen to see if any of our teams are interested that had not already signed up for a slot. And I do have several of those teams that have initiated their schedule with Dr. Gretchen already. So if you're interested, just shoot me an email or any of our project staff. And I'm sorry, Brianna?
In the chat box, we do have a comment from Brittany Klein asking about where is the training and how do we sign up?
Yes. So Brittany, the training comes to you. Dr. Gretchen is so graciously agreed to come down and to the centers and do the training for all the staff who would benefit from the motivational interviewing training. So OPQC takes care of logistics with Dr. Gretchen. All that we ask of you is 3 hours of you and your staff's time and a location to do the training. So if you're interested on either of those dates, please let us know, and we'll do our best to begin to coordinate. All right. Any additional questions today? And there was another one additional question here. Are there CEUs available for the training? I will follow up with Dr. Gretchen. I don't think so, but there might be. It would be something that she would have to process on her end. I know OPQC doesn't offer them, but she might. But I will ask that question of her. All right, very good. Well, if there's no further questions, we'll be sending out a follow-up email after today's call, and I thank everyone for their time today. So have a great rest of your day and a great rest of your week.